Every year at Pinnacle, we kick off the last day with a special bonus session. Cases from the Fitch Files is a Pinnacle standard. And as always, my colleague and partner, Guillermo Fuentes, or as we know him, G-Man, will take you through some of the interesting things that we've been up to these past several months. He's joined by a couple guys that you're going to recognize, Fitch Senior Associates Thomas Moore and Todd Sheridan. So without further ado, Guillermo, what's been happening?
Well, I think the most important thing that's been happening, and everybody has to be honest, is we've learned to live with only formal wear on the top half of our body and shorts on the bottom half of our body. And anybody who doesn't do that is really missing the boat because, of course, COVID tells us to do everything by Zoom. So here we are. The second thing I got to say to everybody in the crowd is thank you for joining us. And I really have missed the camaraderie this year of our conference. As you know, I specialize in happy hours, and my level of engagement really improves every drink that somebody gives me. So I really have missed that. I've tried to keep up with the virtual engagement, but it's never the same as being there live and in person. And I'm really hoping that next year we get to re-engage in a more personal way. I don't want to spend too much time really talking about COVID, but we have to. And the reality is, and two of the presentations today are going to deal with some of the innovations that our Fitch team had to come up with with the face of COVID right in front of us, and like everybody else being a little bit less prepared than we should have been to meet that challenge. So we really worked hard at coming up with some innovations, and then we wanted to share them with you. This would have been an excellent session really to have everyone share their innovations. I think the second wave is coming. Every expert has mentioned it. Every expert is talking about it. And the reality is, I think the second wave will be a little more difficult than the first because it will coincide with the regular flu season. So when that happens, you're going to have a spike in call volume for your regular flu season. You're going to have to deal with that issue. And now you're going to have a confounding factor that the symptomology, the presentations will be very similar clinically to the COVID. So I think one of the reasons we kept this last from the Fitch Files, we try to really bring home really a very practical perspective, and then we share those practical perspectives with the group and hope that the group can then put them in play the same way we did. So I'm going to turn this over to TJ. For those who don't know him, that's I guess facing the screen, the one on the right, and Todd's the one on the left. And they'll take it from here. And then I'll come in at the end and tell a little bit of a personal story and tie it back to one of the previous Pinnacles. So go ahead, TJ, please. I can't hear you, TJ.
Go ahead and unmute, TJ. You got love.
All right. Can you hear me now?
There he is.
You're good. You're good.
All right. Can you see my screen for the slideshow?
Yes, sir. We're seeing your screen. Looking good.
Perfect. So I'm delighted to be with everyone again this morning. It's been great to, despite the challenges of not being able to travel, to hear insight and wisdom shared from thought leaders throughout the industry. Today, I'm going to highlight essentially three key areas that we encountered as we work to address the challenges that the COVID-19 pandemic would bring and ultimately became mainstays in our everyday operations. To give you a little bit of background information, I serve as the Director of Emergency Medical Services for University Medical Center in Lubbock, Texas. It's a 494-bed public nonprofit hospital, serves as the region's only level 1 trauma center and burn center. And the EMS system in this community is hospital-based. It's comprised of ground ambulance transport, the regional 911 communication center, as well as the regional transfer center for several communities outside of just the locale where the base of operations are held. The population is a little over 300,000, and annual run volume for the ground ambulance transport side is a little over 40,000. So you can see that the system scope and responsibility is broad and it's far reaching. as we encountered challenges that the COVID-19 pandemic presented, we really wanted to implore a three-step approach to tackling any of those issues. And it's best summed up in three words, which are engage, identify, and partner. We wanted to engage our partners in public safety and in healthcare, as well as the community at large. We wanted to identify their needs and then determine if we had any capabilities that we could use to assist them in whatever it was that they were dealing with at the time. And then we wanted to partner with them on some actionable strategies to serve the residents and visitors to the community, to the hospital, to the other healthcare organizations in the city. And that's really the approach that we took. The first area that I want to highlight deals specifically with communications and care delivery. So one of the things that we encountered as we engaged communication centers throughout the region, in rural areas, in some larger cities, was there was a need for emerging infectious disease screening tools, for quality improvement standards and indicators, for protocols that they could use to triage, to call take, to do things of that nature, because, you know, in essence, we hadn't essentially encountered an emerging infectious disease of this caliber in quite some time. And so what we did is we worked with them to determine what their protocols and processes were, what we could offer that may be of assistance or benefit to their day-to-day operations. And we collaborated with them to share that information, to share those quality improvement indicators and standards, to share the key performance indicators for the screening processes, to share those screening tools so that they could still provide you know, efficacious resource allocation and quality care without necessarily having to try to outsource or, you know, work alongside other communities that may not have the same infrastructure or capabilities, specifically in some of the smaller and more rural communities. One of the things that we encountered from a care delivery perspective is that there was a need for non-transport protocols as it related to specific suspected COVID-19 patients. In addition to that, there was a need for protocols for skilled nursing facilities and for correctional facilities where we understood and knew that there would be a large populations of patients that had already been confirmed as having the coronavirus. And so we worked to develop non-transport protocols for correctional facilities, skilled nursing facilities, and general non-transport protocols for day-to-day responses to residences. And then what we also did in an effort to reduce the amount of exposure that all first responders were subject to is we partnered with the local fire department and said, what we'll do, instead of having to, on every single response that you send a fire apparatus and a team of firefighters, is we'll equip quick response vehicles and we will send a single paramedic in a quick response vehicle into the residence or into the facility first in Tyvek suits and full face shields and respirators to do a primary assessment, ascertain whether or not they think the patient could be a suspected COVID-19 patient. And that way we were really able to practice time, distance, and shielding without running the risk of exposing other providers to hazards that could be present in the residence or in the facility itself. The next area that I really want to highlight here relates to PCR and antibody testing. While citizens throughout the country and in other countries were ordered to stay at home or shelter in place, EMS, fire, and law enforcement professionals were on the front lines. They remained steadfast and still continue to do so today, and they weren't at home for the most part of the time. And so what we wanted to do is we wanted to work with them to identify if they had mechanisms established to test their personnel, whether it was for antibody tests or for PCR tests to determine if they actually had the virus at that time. Now, what we were able to determine is that there were limited avenues that they could travel, so to speak, to seek PCR testing or to seek antibody testing. And so we work with them to identify some dates and times that worked with their schedules. And after doing so, we hosted a 5-day, week-long time frame where we provided free antibody testing to every law enforcement professional, every EMS and fire department professional in this region and in many others. We set up certain locations to have established testing stations so that they wouldn't be burdened. They could come by while they were on duty. We also would go to their facility if it was more conducive to the work that they were doing, and we would provide them with free testing so that they wouldn't have to be burdened with what they were already dealing with in their regular day-to-day operations, in addition to mandates that may have been passed through executive orders from state or local legislation, and just kind of the overall unrest that I think most communities have experienced from individuals unfortunately having to be sheltered at home. And so what we did is we tested over that 5-day period. We tested over 700 EMS, fire department, and law enforcement personnel from over 20 agencies. And those individuals, one of the questions that we did ask them to answer, just so we kind of get an idea of where we were looking at from a catchment area, is what community were they from? And what we found is that of those individuals tested, they represented more than 24 communities. And so we did that for the 5-day period, and then we realized that was continuing to gain traction. And so what we've done since May is we will work with any of the agencies that I mentioned previously, and if they have individuals that want to be tested or that didn't have an opportunity for whatever reason to be tested, maybe they were out of work at the time, then we will actually set up a time and a date, and we'll set up a testing station, or we will go to their place of business so that we can provide them with that. We really felt that it was our duty to try to provide a service and to give these professionals an opportunity to determine whether they had been exposed to the virus, because they're on the front lines taking care of each of us each day. The next area that I want to highlight in the last one deals strictly with collaboration. It was touched on briefly yesterday in the disruptions in healthcare session. It was also discussed in the leadership roundtable, and that's that there's been somewhat of a immediate shut off of the faucet, if you will, for local institutions that provide, say, nursing education or paramedic or EMS education. And one of the things that we identified is that those institutions were encountering the same shortages for PPE for their students whenever they would go to do their rotations that our providers were, our agency was, and that many agencies across the world were experiencing. But because they were colleges or universities, they were unable to, even when we would give them the name of the supplier, that we had been able to procure, say, N95 masks, face shields, Tyvek suits. Whenever they would contact those suppliers, because they were not a healthcare entity, they were a university, they were often told that those items were not available to them. And it wasn't due to, as the pandemic progressed, it wasn't due to lack of inventory. It was just due to some of the processes that had been established by those suppliers, and rightfully so. So we worked with those suppliers, had several calls, several Zoom meetings with them to kind of explain, they're an institution of higher learning, but the next generation of healthcare providers are in need of the ability to do clinical rotations. And this is why they need the PPE that they're requesting. And we were able to get them to release Tyvek suits, N95 masks, face shields, things of that nature to those institutions. And I'm pleased to report that all of the local colleges and universities are able to continue doing clinical rotations, and they haven't had to go for a long period of time with that faucet shut off. And I think that's important when you consider that whether it's in the nursing disciplines, specifically in emergency medicine, or EMS in particular, if you look at the trend report of previous years, some of the studies that have been done within the last year and a half, we experience a high turnover rate, and it's difficult to recruit and retain. And so making sure that we have an established pipeline that isn't, somewhat stymied by the the lack of inventory or the lack of the ability to procure various things that you need to do clinical rotations, I think is very, very critical to the survival of the next generation of providers, and to ensure that they get the same experience that we would want for anyone to get if we weren't currently navigating this pandemic. One of the other things that we identified, and we found this out in the hospital very, very early in April, is that there was a lack of disinfectant availability, whether it was in the form of sprays or wipes, Cavicide, Sandy wipe, Clorox bleach. Most all of those were on critical shortages. And so we collaborated with a production chemical company and essentially gave them a list of chemical ingredients and elements that the EPA and the CDC had recommended to kill any sort of virus contagions that may be on any object. And they developed a disinfectant. We tested it at the hospital here locally, and it worked just as well, if not better, than the commercial products that we'd been using for decades. And so once we identified that that actually worked, we procured several hundred gallons. We developed education, put out training videos. We made that available throughout the hospital in various areas and sectors within the health system. And we also made that available to 78 other EMS agencies that travel through our region and may transport to our local hospital and other hospitals in the area so that they could disinfect their equipment, their providers, the ambulance itself. And we did that just to ensure that everyone had a mechanism to disinfect their operating area, their environment of work, and provide safe, quality care. So I think, I mentioned it yesterday. It's been mentioned, I think, in just about every session. It's been truly inspiring to see the spirit of resiliency and the level of innovation that most everyone on this call can likely agree we've seen throughout the industry. We've really had an opportunity to shine, and it's been very inspiring to see the great work that's been done and the true genius for renewal that we've been able to experience throughout the industry and across the country. And with that, I'll turn it over to Todd.
Todd, before you jump in, let me there is a question. And first I want to make a comment. I am actually not as orange as I am on the screen, but I can't figure out the light to make me a little lighter. So don't think I'm like I have liver disease or something. It's not that. It's the light. Two, I think if you look at some of the things that you're doing, TJ, I think two things that really strike me is eventually our role in public health is, from an EMS perspective, is clearly going to be much larger. The ability for us to be a mobile vaccinating clinic, and also for us to be the contact tracing arm for the emergency services as a whole, not just for EMS, but for police and others, really does seem to be almost native to what we do. We are having worked both in the police department and other departments of EMS. It's clear that from our perspective, we are the most prepared for that contact tracing to occur from our perspective, and for us to manage that. So it's kind of interesting where you are, and it's good to see there's some things that are coming and emerging from your industry, and I'm glad you're sharing. Kelly has a couple of questions, so I will invite you, Thomas, to look at the Kelly questions. She had two that I thought that were interesting, and I think you need to take a quick look at those. We can either answer them after Todd or before. So just let me know.
I can touch on both of those briefly. Kelly, I can send you kind of the protocol that we've used for testing. One of the things that I did not mention earlier in the session is that we've also partnered with the laboratory within the health system and have been tasked with testing all of Texas Tech athletics. So it's the tennis team, football team, soccer team, track team. If it's an athletic sector within the university, we've worked in unison with the laboratory to test all of those individuals. So I can send you the protocol that we use for that. As far as the concept of disinfecting the ambulance, I think you mentioned here that you were interested in trying to determine, say, a faster method than wipes. One of the things that we did determine, after researching several different chemicals, several different elements, we actually worked with a chemist at the production chemical company that's got about 3 decades in production chemical chemistry. We determined that by changing the percentages within the allowable limits for isopropanol and hydrogen peroxide allowed us to still essentially disinfect any surface with the same amount of efficacy, but we were able to reduce it down to a dwell time of about 1.5 minutes. And one of the reasons that we wanted to do that is in March, we kind of saw the writing on the wall, and we're predicting that there was going to be a huge shortage in gowns and just overall, say, body coverings, whether they're coveralls or say surgical gowns. And so we switched to full Tyvek suits and face shields in March so that we could conserve PPE in other areas of the hospital that may need those critical items. And so we wanted something that we were able to disinfect our actual providers with after every single run. And so the same solution that we disinfect the inside of the ambulance with, we also have a decontamination room in all of the local area emergency centers. And after extensive testing, determined that there were no risks to anyone that may be in contact with it, at least for not extended periods of time, and if they're not sitting, say, in a large vat of the solution, if you will. And so we disinfect our providers with the same solution that we disinfect the ambulance with, and it has a dwell time of about 1.5 minutes. And I can send you the information and the training education that we would develop for that.
Thank you, Todd. Let's move on. Thank you, Thomas. Let's move around to Todd.
Hey, Thomas. Hey, nice job there. And a lot of things that you stated there. I know we were in conversations and documents and going stuff back and forth with this. So a lot of great stuff there. And I'll try not to in mine do anything that overlaps, as I know we were working together there. So first off, I want to apologize. Just now, of course, a construction person had to park outside my window because somebody's doing construction of their house. So if my dogs fire off, I apologize. So, so just to give an announcement there, as you mentioned, my name's Todd Sheridan. I work with Fitch Associates as a senior associate for the firm. Through Fitch Associates, I'm assigned as a management services person and work daily as the Senior Director of EMS and Patient Movement for the Tower Health System, which is a system role there, as the hospital is a 7-hospital system in Pennsylvania with approximately 1,600 beds throughout their entire system, ranging from Reading all the way to Philadelphia, covering the broad spectrums of services from a level 1 trauma center to a pediatric hospital. So it's been great working with them. And, really quickly, I just want to acknowledge, before we get into this presentation, as being part of this team as the Senior Director of EMS and Patient Movement, have quite a few folks that work with me that support on a daily basis, both the hospital and the community. And really, that's Anthony Martin as the Director of EMS, Scott Dunbar as the Director of Quality and Process Improvement, Kara Gagliardi as the Director of Transfer Center and Critical Care Team, both medical directors of Dr. Schiffer and Stauffer, and Chelsea Ober as our EMS outreach. The reason why I mention those folks is it really kind of gives a perspective of the entire breadth of what our EMS and patient movement system is being developed as within Tower Health. So today, we're going to go over to some 3 main areas that we as a team focused on to support both the hospital and the community during these times. Next slide, please, Anthony, or Thomas. So really, for many years, being a community partner has been a strong focus for Tower Health. Tower Health at Reading has supported the Berks County EMS agencies, which is approximately 15 to 20 EMS agencies, through different supply methods, connectivities within the hospital programs such as education. However, during these times, Tower Health needed to kind of refocus its energy and support with this ever-changing environment. one of the regions supporting has the level 1 trauma center within Reading, and in its ability, it collectively works with each one of its EMS agencies and other healthcare systems, where Tower Health participated in as part of the daily calls to help provide guidance for its EMS. So daily, Tower Health wanted to participate and be a part of the community's direction to help provide not only a little bit of that guidance, but also support where needed. And some of those guidance areas that really Tower Health focused on were internally looking at how we as a system were operating, planning, responding, both trying to be safe, and in our clinical aspects of our care. We wanted to provide that same information to all of our community partners so that we could help provide potentially some type of collective response. The way we did that was we provided these documents on a regular basis. If it was daily with any updates we did internally, both from an operation and deployment standpoint to a clinical standpoint. And any clinical changes we may suspect. Any safety measures that we were taking for our staff, we wanted to also pass along to all of our community partners. Now, as I mentioned a minute ago, how did we kind of keep that as a rolling assistance? Well, through that, we created internal documents such as briefing documents or clinical documents where we shared them both with these local agencies, and also because Pennsylvania has regional councils, we shared them with regional councils as well to help support and really share our communications to staff for safety measures that we believe should be taken. We also wanted to bring awareness and guidance to help any agency that may benefit from what we were doing. As we had a large healthcare system, as we knew a lot of EMS agencies were really trying to figure this out as the healthcare system. As we were figuring it out, if it was something we could share, we wanted to give it to our community partners. Also, one of the other pieces we talked about was clinical. As we know, as we were starting to learn about droplets, we were starting to learn about the proper PPE. We also started to understand some of our clinical aspects needed to change in the way we dealt with airway management. So as we were adjusting and we were finding out how we wanted to handle internally within Tower Health, we were providing that same documentation to our community partners so that if they wanted to adopt some of these same processes, they could. Last but not least, in some of this guidance that we had on our daily calls, Tower Health, in working with another healthcare provider that was within our region, started to develop forecasting models for each hospital and each county underneath our catchment area. And these models were shared with both the local agencies and municipal leaders. They were developed really to describe our pre-surge and surge moments for our med-surge beds and our ICU capacity. And really we started forecasting out almost a month in advance of when we saw our projections based on doubling rates and what that would affect the hospital system, but what we could ultimately look at potential volume effects to EMS. This then allowed us to actively start to pre-plan and partner with our community agencies. Now, transitioning over, Tower Health has an established community paramedic program where we have approximately 50 people on caseload at any given time. This is created by a referral pattern set up in our hospital's electronic medical record EMR system through Epic, where the community paramedic, when notified, will go on site, complete an assessment utilizing what's called a STEL device. This device is plugged in at the house, and it uploads information to a centralized computer in public health department within the hospital, where we monitor pulse ox, blood pressure, respiratory rate on a daily basis. And if anything is abnormal, we start to work with that. So that's kind of just a general overview of our community paramedic program. But what started becoming different for us as when COVID hit, we were beginning to understand with elective surgeries, people were still going to have their pre-admission testing. So our community paramedics became engaged with specific departments back one, TJ. Specific departments to complete pre-admission testing for really the following folks. The folks were, the people that had mobility problems or challenges, any at-risk population. Our community paramedics, if these were identified by the specific departments, would go out, complete an assessment, documented in our Epic EMR platform. And in Epic, we would do a COVID health risk screening or scorecard. We would draw blood and we would complete a COVID test. So that allowed our folks for pre-admission testing to be able to be entered into the system prior to them having to come to the hospital. The goal of this program is really to help support specific departments in limiting any exposure for patients that may be at risk by utilizing our community paramedic services. So as we continue talking about supporting the community, really within our environment, as opportunities for treat in place and alternative destination transports started to become a topic of conversation, to decrease transports to the emergency department during the surges we were expecting, utilizing telehealth and some of the newly adjusted regulations allowed for alternative destination transportation and treat in place. And Tower Health team developed an algorithm really so it didn't matter who your EMS agency was. If you were a Tower Health EMS person or if you were a community ambulance, you could participate to help decrease the surge within the health system. Now, that became interesting because as you start thinking about that, how does each agency, how can you leverage that opportunity and really not disrupt some of the current workflows? Well, this process would have had the providers call from the scene and either speak via phone or via FaceTime to the medical command doc, kind of like we do today. And that doc would then help provide guidance, help with the distribution of the patients, let's say to an urgent care that would be close by. And then that medical command doctor would document that visit in our Epic EMR platform. Now, as mentioned earlier about our community paramedic, if somebody and how we get notified, if someone was treated in place or sent to an alternative destination, then the community paramedic for Tower Health would then follow up within 24 hours. And then after 24 hours or after the initial call, if needed, set up subsequent phone calls to follow up with the patient. And if circumstances arose during that call, the community paramedic could then dial in the medical command doc for consultation. So it really kind of brought everything in full circle there to make sure there was some type of follow-up. I'd be remiss, I would love to have been able to put this, our team would have loved to have been able to put this in place. However, fortunately, in the market in which we were looking to enact this, we never really hit that surge moment. So we had it was ready for a surge hit, but unfortunately we didn't have that. But the pre-planning was pretty interesting leading up to this moment. Next slide. Thank you, you're on the right one. So with Tower Health being a newly formed organization, maximizing efficiency across the healthcare system was being done. However, when COVID hit, not all areas had been refined. Tower Health was and is in the process of creating a singular transfer center to manage the transfers in and out and laterally move throughout the health system. Well, in actuality, at this point, as we were starting to develop this process, we were only about 50% complete when the COVID hit. So initially, as a team, we had to identify gaps in our current service delivery. And one of those gaps was that every hospital had a different discharge process or patient movement process, as well as capacity management. So to improve that process, or to improve the discharging process, we had to gain all documents and create one source of truth for that process to discharge. So as our transfer center needed to support both the patient movement and our capacity management, we really had to refine and create that one source of truth. But as capacity management, we realized quickly that two of our hospitals were reaching this capacity really quick. So we had to develop a surge plan, that was created with two thoughts in mind. As we all know, staffing to demand, and lateral patient movement. As with any type of surge or any type of MCI, patient movement is a challenge. In looking at the staffing to demand, we partnered with central staffing for the health system and noted when census was rising and began to work with staffing to ensure the right focus was placed on our personnel resources. Now, as for patient movement and EMS, EMS helped to keep hospitals off to BERT by working to decompress the like I mentioned, 2 hospitals that actually did hit surge, so that we could laterally move patients throughout the health system to other hospitals that had capacity. Now, the transfer center took a new role as becoming that nerve center for the health system as they began to recognize trends prior to even the hospital command post. So that nerve center really became a singular focus for the health system. So now that we started to operate, back from in a recovery mode, the hospital saw the advantages of what the transfer center was doing. So and how they were working with different departments. So because they're seeing the benefit of co-locating and working together on a daily basis for pre-surge and surge ability to avoid like future diverts or create diverts that are only short-lived, that Tower Health system is working to co-locate specific groups and partner functions such as virtual and central patient monitoring, central staffing office, transfer center functions, bed management, patient placement, and EMS dispatch. Next slide. Next slide. So one of the unique moments for Tower Health team was when our EMS director was assigned as the incident commander for Tower Health Systems Command Post. The command post served as the single point for the 7 hospitals command post. So the Tower Health Systems Command Post, in essence, operated as an area command to focus on the system needs, the reallocation of resources to appropriate areas, and develop system communications in our system communications in our response efforts. This was a unique movement as the health system recognized with nearly every disaster, there's a patient movement issue. Next slide, or you're on the slide. Thank you, TJ. This allowed EMS to be part of the decision, be a part of the decisions being made throughout the health system, and gave our team a unique perspective as to where we need to focus our energy. One of the real advantages, as mentioned early with EMS outreach that the hospital had done, relationships have been established prior to COVID, allowing our team to really liaison between the hospitals, the EMS agencies, and all the municipalities in which we served. As part of this in the command team, having that unique and real-time perspective allowed us to really adjust our focus and become strategic. So once we started to become strategic, we started becoming engaged on a daily basis, and even our teams reported out in the command staff meetings, both from a transfer center perspective on census and surge, as well as patient movement for EMS for the needs for lateral patient movement, all the way to even at times having to decompress our morgue. When patient movements were needed, we were able to reach out to our transporting partners to help mitigate these issues in really real time as they were coming up. So another area of focus for our command center, we focused on forecasting models when they were created, and that helped us understand what was happening in our communities. Because we understood the what was happening, we shared that information with the counties and agencies so that we could help them understand the how they needed to respond. This became a very important and expected role of us as we started transitioning and working with, again, as we started talking with our community partners. Really kind of the last point, and we'll bring up here so many other ones that you could hit from in this presentation, but as everyone here probably experienced, was the PPE challenge, or the need to change our current procurement methods. Tower Health, who was in consistent communication with those municipal leaders, began to see some of the same issues within the community. With the group of individuals from the health system who were solely focused on procurement, Tower Health was able to help the municipality secure approximately $2 million worth of PPE to support our community partners. So, really, as COVID, COVID has taught us much about our organization and processes. Our teams have learned a lot about its ability to support both the health system and the community. Relationships, and we've talked about this for years, relationships building prior to the event were really key to being able to partner, adjust quickly on the fly, and then be assigned at the table to support everyone's needs at the time of crisis. So that relationship building and understanding our roles early really helped us be able to move our system forward. So with that, I will turn it over to you.
Thank you. Thank you very much. So as you saw, we tried to give you a perspective, 40,000 foot level of both planning, community outreach and partnership, and a very grounded level of transactions that need to occur both with your partners and with your own organization in order to keep both your staff safe and serve your population well. Like I said, this could be a subject, it would have been a great subject to do in person and have, I'm sure 100 different questions and everyone can participate, because I'm sure within the innovation industry of EMS, I think everybody has innovated around the COVID issue. I want to take you, if I can, through a little 5-minute, more personal presentation. It's not a presentation per se, a little discussion that's more grounded, has nothing to do with COVID. But I thought I would share my experience only because in many ways, when we talk at Pinnacle about, some of the issues that are sticky and people don't really want to sit through those sessions and they come out a little aggressive or angry, it's always good to know that in the end, it's because those issues are real. So last year, there was a discussion, one of the Pinnacle sessions was really on transgender and what that effect has on providers, and then how to try to mitigate that effect on providers, and then what do we do with that. And so for those who don't know, I've had a pretty tragic year. I had a passing of a son and then a near passing of a daughter. My daughter is transgendered. So I'm going to take you through the event in a pretty quick, high level way, and then just let you take away and simmer through that, where it does affect human beings. So on January 31st, we had our daughter called us to say she wasn't doing well. She needed help. My wife went to get her. We got her, we put her in bed. That was at 4 o'clock in the afternoon. At 5:30, her respiratory rate was diminishing quickly. And we decided to call the ambulance service. The ambulance service triaged it correctly. It came a 6 Delta, which was difficulty breathing for those who don't do the MPDS codes, lights and sirens, and the paramedics attended. Paramedics, she was in a bedroom, not well lit. Maybe the orange light's a thing in my house, so who knows. The paramedics put on the monitor, the pulse oximeter. Now she's a 35-year-old lady, so she doesn't obviously generally compensates pretty well. Our history was that a couple of days before she had been diagnosed with a pneumonia, and she seemed to be having problems compensating for the pneumonia. The paramedics, after putting on the machine, the pulse ox and the other vital signs the machine will pick up seemed to be appropriate. So the paramedics were already starting to relax, and before they started their primary and secondary assessment of auscultation and other things, my wife mentioned to the paramedics, my daughter's transgender. Now we had learned, so my wife had learned last year at Pinnacle that you have to mention that they're transgender because of course their heart and pulse rate will be different if they're male of birth and then female of appearance. The freeze was almost immediate. At that point, there was no secondary assessment done. There was no auscultation. And so several things were missed. One of the things, even mentioning that I should mention ahead of time, this is a world-class service, rated always in the top 10 of paramedic service clinical outcomes. They do a fantastic job. So this is not about the service. This is about the reaction to the transgenderism. At that point, they froze. They didn't do the secondary procedure. So they never auscultated the lungs, and they never looked at the chest. My daughter had, at that point, significant bruising was occurring on her body, and she was having significant difficulty breathing. So much so that I mentioned to them, you can actually see the ancillary muscle groups that she's using. You really need to pay a little more attention to her and less to the machine. It was a little bit of a discussion. They agreed to take her to the hospital. So they take her to the hospital, no lights and sirens, no medication, no oxygen, none of that. They end up at the hospital. And one of the things that's impressive, and I need to reiterate, we have really grown as a profession, the paramedics. The hospital nurse will rely very much on the clinical presentation that the paramedics give. So the paramedics give this clinical presentation to the nurse listens to the clinical presentation, and my daughter is then transferred onto a wheelchair and into the waiting room. An hour and a half later, she is called in to get an x-ray, thinking it's a follow-up for the pneumonia that they clearly have passed on to the nurse. She's been suffering for an hour and a half. She's in pain. Nobody's really attentive to her. My wife has tried several times to get her moved up. Nothing's moving forward. They get the x-ray, and right away, the scenario changes. First thing the x-ray tech notices is my daughter has a collapsed lung. And she's got significant fluid buildup on the left-hand side where the collapsed lung is. And then there's other things that he doesn't even recognize, the x-ray tech. So he calls the doctor in, and now the motion starts. I will save the end I'll get to the end pretty quickly. 5 hours later, she went to surgery at Hamilton from Niagara. They don't have a thoracic specialty. They opened her up, and she had necrotizing fasciitis, or flesh-eating disease. The doctor that opened her up said he could reach in and pull out the flesh that was attached to her chest cavity with his hands, and basically spent 5 hours debriding her. 13 operations later, 20 weeks, and she was released from hospital. So and she's now staying with us. I don't want to end it as a tragic story, but this is real. When we talk about some of the sticky issues at Pinnacle, and sometimes we try to say to ourselves, that's not our organization, it's somebody else's organization. It wouldn't happen if with my people. It does happen. This is dealing with the minorities, dealing with the outsiders and the smaller group and communities is something that we have to be purposeful about. Having experienced it firsthand from a world-class system, I can tell you it's something that we still need to work on. And so I don't want to leave you on a negative. It's very positive. She's doing great. But I wanted to share that story with you so that you had a real life perspective on some of the issues that we talk about. With that, I'll turn it back to Anthony.
Thank you for sharing that, G. That's a powerful story, and I know just as everything else from our cases from the Fitch files is some great information we really all need to be paying attention to and take a closer look at the care we're providing and how we're taking care of one another. Thank you, Todd and Thomas, for all the information that you guys shared today. We got some really good questions that came through. I believe Chuck has put email addresses out there for Guillermo, for Todd, and for Thomas. I believe he sent a chat to all the attendees. If there's some information that you would like to further follow up on that these gentlemen shared with you today, please reach out to them. Normally you'd be able to go up and talk with them at the end of a session and or over a cocktail or something like that. But unfortunately we're not together and can't do that today. So send them a note and they'll be glad to get back with you. I think I also heard that it might be Thomas's birthday. Is there any truth to that? No?
Happy birthday.
No, I wasn't going to the group in a chorus of happy birthday, but Todd is obviously, he likes his so. DJ, happy birthday, man. Go grab some cake.
Yeah, we can forego the music, but thank you.
What are you saying about my saying?
Well,
I'm saying you shouldn't quit insulting.
you know,
I'll keep doing that.
we've reached the end of Virtual Pinnacle, and as promised, it was shorter but filled with timely and relevant content that I hope you found insightful, useful, and at times even entertaining. We truly regret that we were not able to be with you in person this year because, like you, we miss our friends and colleagues. I do, however, hope that over these past few days, we've been able to provide you with a brief respite from the challenges you've been facing and maybe bring you a little of what makes Pinnacle so special into your office or home. As we continue on through and until we see one another again, we'll keep bringing you the Pinnacle webinar series each month. And these informative sessions are brought to you by our Pinnacle sponsors. Here's a lineup for the rest of 2020. On the screen, you'll see that coming up in August, we've got navigating reimbursement in 2020. September is going to bring understanding ambulance insurance for EMS owners. October, balancing goals, the value of optimizing efficiency through dynamic deployment. November is currently pending. We are waiting the sponsors session. Then December, we're going to see achieving maximum revenue cycle performance through interoperability. So we hope you join us for one or all of these great webinars. Please visit www.pinnacle-ems.com to find this list, to get signed up for a webinar, or to watch one of the previous sessions, one of the previous webinars that have been presented in the last few months. You'll also be able to find recordings from Virtual Pinnacle, as I've mentioned along the way, and you'll also be able to keep up on all things Pinnacle related. You know, as we come to a close, things like this don't just come together overnight, and I wish to thank all the fabulous speakers who gave so much of their time and knowledge this week. And thank you to my partners, Jay Fitch, Christine Zoller, Guillermo Fuentes, Roxanne Shanks, and Steve Knight, along with Senior Associates Todd Sheridan and Thomas Moore, and Senior Consultant Bruce Moeller. You guys really put a lot of work and time into this to make this a powerful conference, and we really appreciate it. Finally, I have to give recognition to some very important people from our Fitch family who made this Virtual Pinnacle conference possible. Matt Darty, Chuck Walker, Sharon Conroy, and John Chamberlain and his crew. Without you folks, we couldn't have brought these very special sessions to all these wonderful folks who attended. You're the think tank, the creative force, and the backbone behind this, and I owe you all a debt of gratitude and a world of thanks. As we bring this to a close, I'll say that we miss you, and we hope that you're all well and safe. Please take care of yourselves, your family and loved ones, your agencies and communities, and one another.